All right, today we're diving into microsporidiosis, and we're going to do it by focusing on the two big players, Enterocytosome bianusi and the Encephalidosome species. Now, you might think they're similar, but trust me, in the clinic they act like completely different beasts, and figuring out those differences, well, that's the key to really understanding this whole topic.
You know, this quote just nails the paradox of Microsporidia. These are not simple bugs. They are, in fact, masters of reductive evolution. They have strategically thrown out cellular parts we thought were essential, creating this incredibly efficient parasite that can be absolutely devastating, especially for anyone with a weakened immune system.
So first things first, let's get this straight. For decades, we had these organisms completely wrong. We all thought they were primitive protozoa, but genetics came along and changed the game. We now know they're actually highly evolved fungus. In a wild evolutionary move, they basically jettisoned complex things like mitochondria, leaving behind these tiny remnants called mitosomes. This makes them 100% dependent on their host for energy. I mean, that is the ultimate parasitic lifestyle.
Okay, this table right here, this is your Rosetta Stone for microsporidiosis. Every single line explains a crucial difference. Look at Enterocytosome. It hangs out right in the host's cytoplasm, so it tends to stay put in the gut. But Encephalidosome, it cleverly hides inside a vacuole, which acts like its own little escape pod, helping it travel all over the body. But the real kicker, look at that bottom line. That one difference in drug response, it dictates our entire treatment plan. These 4 points are the foundation for everything we're about to cover.
So how does this minimalist fungus actually get inside our cells? Well, it uses one of the most incredible invasion mechanisms in all of biology. When a spore senses it's in the right place, like your gut, it doesn't just knock on the door. It shoots its way in. A coiled-up polar tube fires like a harpoon, punctures the host cell, and ejects all the parasite's guts right inside. It's basically a biological hypodermic needle, and it happens to be one of the fastest events known in nature. It's truly amazing.
Okay, Section 1, Diagnosing the Invisible Enemy. So that wild invasion kicks off an infection, but actually finding these tiny organisms is a huge challenge. Let's get into how we track them down.
For years, all we could really do was use stains to confirm that, yep, Microsporidia were there. And that's useful, but it can't tell you which one you're dealing with. And as we just established, that distinction is, well, it's everything. And that is exactly why PCR has become the absolute method of choice. It gives us the precise species identification we desperately need to pick the right drug from day one.
So let's put this into practice. Picture this. You've got a 55-year-old renal transplant recipient, so they're severely immunocompromised. They come in with a fever, a cough, and their brand new kidney is starting to fail. You run all the usual tests for infections, and everything comes back negative. What do you do now? Where do you go from here?
The clues are all right here. A really vulnerable patient, a vague illness that's affecting multiple systems, and nothing from the standard cultures. This just screams opportunistic pathogen. Now, the most common mistake here is to get fixated on the gut and only test a stool sample. But the illness is systemic, right?
And boom, this is the pivot point. A sharp clinician thinks outside the box, broadens the search, and finds spores in the urine. This is a total game changer. It immediately tells you this is a disseminated infection, not just something stuck in the gut. Finding the organism was all about looking in the right place.
And finally, PCR comes in and gives us the name Encephalozoeon sineculi. This case is a perfect example of the diagnostic algorithm in action. When you have a compromised patient with systemic symptoms, you have to think beyond the GI tract and test the urine. The PCR result not only explains the entire clinical picture, but also tells you exactly which drug is going to work.
All right, on to Section 2, the Great Therapeutic Divide. That diagnosis is so critical because, as we're about to see, the name of the bug dictates the drug.
I mean, it really doesn't get much clearer than this. Encephalidosome species, they're susceptible to our go-to drug, albendazole. But Enterocytosome bianusi, it's just flat-out resistant. The drug doesn't work, and this isn't something it learned. It's not acquired resistance. It's a fundamental biological fact about the organism. And that's why getting a species-level diagnosis isn't just academic, it's absolutely essential for patient care. But here's the thing. Drugs alone are often not going to cut it. The single most important thing, the true cornerstone of management, is immune reconstitution. You have to help the patient's own immune system get back in the fight. For someone with HIV, that means effective antiretroviral therapy. For a transplant patient, it's a really delicate balancing act of lowering their immunosuppression without triggering organ rejection.
So this table shows you what we've got in our toolbox, and as you can see, it's pretty limited.
For encephalozoin, the path is clear, albendazole. But for EB-UCI, our most common one, we're in a real clinical bind. The best drug, Fumagillin, has some serious side effects, and on top of that, it's not commercially available in the US. This forces us to use alternatives like nitazoxanide, which just doesn't have the same level of evidence behind it. It's a genuine dilemma.
And that dilemma brings us right to our second case. You have a leukemia patient on chemo, so they're very immunocompromised. They've had this debilitating diarrhea for 7 months that just won't quit. A high-tech sequencing panel is done. Knowing what we know now, what species are you betting on?
And the diagnosis comes back, enterocytosome BNEI, just as we would predict. And, of course, a trial of albendazole does absolutely nothing, which confirms its clinical resistance and puts the medical team squarely in the middle of that therapeutic dilemma we just talked about. So, with Fumagillin off the table, they went for the pragmatic choice, nitazoxanide. And in this case, guess what? It worked beautifully. The patient started feeling better in just 3 days and went on to a complete cure. This case is a great example of nitazoxanide's emerging role as a viable option when your back is against the wall. It's really a testament to adapting your treatment with the limited tools you have.
Okay, moving on. Section 3, Control and Prevention. Look, curing an infection is great, but preventing it in the first place, that's the real win. So how do we break that chain of transmission?
In a hospital setting, it all comes down to the fundamentals. We're talking standard precautions and strict hand hygiene for everyone, and then bumping that up to contact precautions for patients with diarrhea. And the good news is, while these spores are pretty tough, they're not invincible. Simple things like boiling, deep freezing for a couple of days, or just 70% ethanol will take care of them.
And for our at-risk patients out in the world, the advice is really practical and empowering. We know water can be a source, so boiling or filtering is key. With food, it's all about washing fruits and vegetables really well. And since animals can carry these bugs, meticulous hand washing after any contact, especially with pets, is just non-negotiable. These simple steps can make a huge difference.
All right, our last section here, long-term consequences. So what happens even after the active infection is cleared? Well, sometimes the fight isn't quite over.
And wouldn't you know it, the long-term problems map directly back to our 2 genera. A chronic EB-MUC infection can really damage the gut, leading to lifelong issues with malabsorption. Disseminated encephalozoin can leave a permanent mark wherever it went, causing things like corneal scarring, chronic kidney disease, or even lasting neurological problems.
And this brings us right back to the most important principle of all. If you remember one thing, let it be this. The ultimate outcome for a patient with microsporidiosis hinges almost entirely on their immune system. In a healthy person, it's no big deal. But in a severely immunocompromised patient, the prognosis is much more serious, and their survival really depends on our ability to help their own body fight back.
So we end on a really critical question for the field today. Enterocytosome BNI is the most common species we see, but our best weapon against it is basically off the market. This leaves us in a really tough spot, trying to manage our sickest, most vulnerable patients with second-best options. It's a situation that just screams for the need for new research and better therapies.